Excuse me. Good morning. Hello, I'm Dr. John Kruse, and welcome to today's question and answer session. We have an hour where I can try to answer questions about the videos I released last week, about ADHD in general, or more broadly about mental health. As usual, the comments I make are intended for informational purposes. They're not intended as specific treatment recommendations. What else can I say? There was one question left over from last week, so I'll try to get to that too after reviewing briefly the two videos. And I am not seeing, okay, now there are signs that some people are there. So the videos that were released in the last week was a new updated one on trigeminal nerve stimulation and a sound re-recording on fidgeting and ADHD. So the fidgeting video, the thrust of it there was that fidgeting isn't just some annoying, irrelevant behavior that is associated with ADHD, and it is one of the um, symptoms that's most strongly or comes across as a core issue of ADHD in some cluster analyses. But there is some good evidence that fidgeting isn't random, that it is associated with concentrating or need to focus, and that it actually the motor action does actually seem to help promote greater concentration. So that's what I'll say with fidgeting. For trigeminal nerve stimulation, the original video came out in 2020. So that was a year after, I'm blanking on the name of the company, produced the UCLA team, produced a trigeminal nerve stimulation device. Has a big electrode patch on your forehead. It was called the Monarch. You use it for 8 hours at night. There were two small studies in children indicating it was helpful for alleviating ADHD symptoms. The FDA's requirements for a device are much more loose or lax than they are for approving a medication. So essentially, all they're saying is that the good appears to outweigh the bad and it may have some benefit. But anyway, it was approved. It doesn't look like it's actually sold spectacularly well. I mean, it does sell for $1,000 a device about, and indications from the company's website is they've sold fewer than 3,000 devices in 6 years. But a recent study in December 2025 just came out, done by a different team of researchers, a multi-site location, much larger number of individuals, and the media has widely reported this as showing TNS doesn't do anything for ADHD. And there's a distinction to be made that in the study, the TNS treatment did not differ from the sham or placebo treatment, but both groups showed about a 12, on average, trying to parse the data from the figures given, about a 12-point decrease in an ADHD rating scale. That's comparable to the effect size found in several non-stimulant medication trials. So that's not trivial. Part of the question is, why was there such a big placebo rate? The investigators cite that they had a more convincing sham treatment. So the original studies, I mean, one was an open study, no control group. The second one was a controlled study. There, they just had a deactivated device that was on people's forehead. With this recent study, they had a device that went on at a much lower amplitude and different wavelength for 30 seconds every hour, but then at least maybe created more of an illusion of an active treatment. So I would say it's premature to abandon TNS completely. The original group, the UCLA team, is conducting a multi-site, large number trial that should be finishing sometime early this year. And hopefully the results will be published sometime later this year or maybe next year. So hopefully we will have more information about whether TNS is really effective or who it might be effective for. So I see one question from Max coming up, but I'll try to get to. So Rick 007 asked a question last week. citing data or asking whether I was concerned about data suggesting that memantine, which is used and approved for Alzheimer's, it's a NMDA glutamate blocking drug, um, that there was some evidence that it caused sort of hippocampal burnout in rodent models. And I wasn't able to find a particular study that suggested it. There was an early study in 2006 that indicated that the dosages needed to prevent to have neuroprotective effects to prevent neurons from dying did seem to impair both motor activity and cognitive behavior in rats. However, there have been several studies published in the 2020s, um, again, looking closely at neuroanatomy in animal models, and there have been cases in humans where there's no sign that memantine in these studies is causing any neuronal damage in the hippocampus or elsewhere. So um, I can try to research some more if there's a specific article, but that's what I've come up with so far. So, hello, Max. In practice, it sometimes seems like psychiatry is more about treating symptoms rather than conditions. Do strict categories of conditions go out the window in clinical practice? So, I'll say a couple different things. One is that there are plenty of people who do seem to have classic depression, classic ADHD, classic bipolar, classic schizophrenia. So, in many individual cases, there is moderately good overlap between our symptomatic descriptions and our nosology, our system of classification for psychiatric conditions. On the other hand, there's lots of people who have multiple conditions, lots of people who it's not clear which category or condition is the best label for them. Um, so I think if someone fits a classic pattern, we try to treat that. And beyond that, people, my impression is try to treat the most salient or problematic set of symptoms. Now, one is the patient may have a different understanding or belief or conviction that certain symptoms merit more attention than the treating physician or nurse or physician's assistant might consider what's most important. Part of what's difficult, and it's hard to say without sounding pejorative, we know that insight and awareness in many mental health conditions is impaired or affected. So, whose version of reality or whose priorities are you going to listen to? The second thing, and I have not looked into too closely the specifics, but they've just announced in the last week that they will be completely revising the DSM, which for most of its iterations, most of its versions in the last 50 years, I'll say, have been strongly based just on symptoms and not on what's the cause of this, that they're going to be moving more towards what many have been encouraging, which is the research domain criteria and trying to identify clusters of brain functions that are tied to aberrant neurochemistry or neuroanatomy or neuroactivation. And they will be moving away, perhaps, from our current diagnostic categories. So that will be interesting and controversial, and we will see where that goes. Hello, James Alexander. Um, what are plausible explanations for why over 50% of ASD diagnosed patients also have ADHD, but only 15 to 20% of ADHD diagnosis patients have ASD, assuming those figures are correct? So those numbers are what the number of different studies come up with. So that is close to half of people with an autism spectrum diagnosis also have ADHD symptoms, but while it's a disproportionate number, it's a much smaller percentage of people with ADHD actually have autism spectrum problems or symptoms. So one is there's evidence that are some common genetic contributors, but there are also distinct genetic contributors. So So part of it could be that that there may be certain class of genes which contribute to both ADHD and ASD, and those are more prevalent in the population than those that are unique to ASD or unique to ADHD, and that there's a greater pool that convey a risk for autism. Uh, there's a greater pool that convey a risk just for ADHD without the combined risk. That would be one set of explanations. I don't know if I worded that very well. So again, it may be that we have a set of genes that are only predisposing to ADHD, that those are moderately common, that there's another set of genes which predispose to both, which are somewhat less common, and that there's even a smaller number of genes that are predisposing towards ASD, but not necessarily to ADHD as well. Um, Yeah, I will leave it. And when I'm saying genes, I'm also going to include epigenetic modifications of those genes. So genes in action is part of what I would say. Um, so I don't know to believe this, that there's a common pool of genes which can contribute to each of these conditions, but there are environmental conditions which would push, like, they may be family parenting traits, they may be environmental toxins, they may be a whole host of different variables, but given that genetic predisposition to either condition, there could be environmental factors which push more strongly to evoke just ADHD symptoms, or more commonly than evoke combined symptoms, and again, less commonly just pure ASD symptoms. So, so thanks, Max, for including a link to an interview I had a few months back. Bert Martinez, many of his interviews are sort of business entrepreneurial focused, but he felt that what I had to say about ADHD and increasing prevalences of it and societal aspects of it, and also going from my first book, What Donald Trump Can Teach Us About ADHD, might have useful information to the general public. So I encourage Max is doing the heavy lifting here, providing all the questions. What else? I'll read his question in a moment, but encourage, there's a few others out there to ask whatever may be on their mind, again, related to the videos that released, related to ADHD more broadly, related to mental health more broadly, and I will try to answer them. Sometimes I go a little long at the end, but I am locked into an hour today because I have a patient afterwards. So Max asks, if an adult lived their whole lives with a mental health condition, are they usually less capable of determining what may feel better when trying treatment since they never lived without it? I'd say that probably depends on the condition. So I have certainly seen individuals in their 40s, 50s, 60s with ADHD, and clearly a pattern of ADHD symptoms from childhood. And when they finally got on medications that worked, they were delighted and amazed, and often a fair amount of regret and sometimes irritation, anger, resentment that their condition wasn't diagnosed earlier. So that, I mean, specifically for ADHD. On the other hand, I've certainly seen people, and these were particularly seniors, as I would say, people in their late 60s to 70s to 80s to 90s, who also had clearly robust histories from childhood and current presentations of ADHD, and not particularly strongly any other thing, even though some of them had been treated for years for anxiety or depression or others. And they were very reluctant to accept an ADHD diagnosis. So and therefore reluctant to try treatments that might be helpful in that situation. So, another question, and I'm going off on a tangent with this one that's related, is that again, the field currently makes a sharp distinction between primary ADHD developed in childhood, presumably with a strong genetic predisposition, versus secondary ADHD, which may mimic a whole host of ADHD symptoms, and it may be as a result of traumatic brain injury or post-COVID conditions or some other set of environmental other triggers. And one question is I mean, even if the current presentation is a full range of ADHD symptoms, the fact that the person up until the age of 37 or 45 or whatever it is did not have ADHD, does that influence either comorbid or concurrent other conditions or how they see themselves or how they see their set of symptoms or to the degree or extent to which their ADHD symptoms impair them? So that's what I'd say there. So James Alexander asks, some ADHD patients claim that for some stimulant medications, they feel wired, anxious, experience hard crashes after it wears off, have heart pounding and dry mouth, and get an energy boost or euphoria for the first week taking it, and only after a week stop experiencing these side effects and just feel focused. If a patient was willing to come in as frequently as necessary for follow-ups after being prescribed a stimulant, e.g. once a week or even every day, how soon would you wait before upping their dose, or for example, Vyvanse, if they weren't feeling any benefit, or decreasing their dose if they were experiencing unpleasant side effects? So I'm not su so some of what we're discussing is sort of the negative effect of honeymoon effects. So I do have a video on honeymoon effects, and I'll just say that maybe up to half of people in their first days on stimulants feel benefits more strongly than they ever feel again, that they can't ever recapture it, and there's still debate as to how much of that is physiologic upregulation of receptors or other factors, just meaning they're really not getting the same effect, and how much of it is psychological, sort of getting back to Max's earlier question, that having relief from their symptoms is so great a benefit, that there's a halo effect, that they're not looking closely at what's still not being completely treated by ADHD. But so moving some of that aside, and this is sort of the negative honeymoon effect, what I tell people when I start them is that the commonest side effects of the stimulants are feeling revved up, agitated, wired, sometimes trouble sleeping. And this is a judgment call, and it's up to the person experience. If it feels mild, if it seems to be decreasing after a few days, then it's usually worth persisting because it will likely continue to persist. But we know for some people, the starting dose, even if it's a low one, is just too much. And particularly if it's getting so, part of my criteria is how long to tell people to stick with it and when to go up or down is one, the severity of what they're feeling at the time. And absolutely, there can and should be a subjective element. So my level of comfort with some anxiety may be higher than or lower than yours, and I shouldn't impose my level of comfort with feeling somewhat anxious. If they're anxious about their anxiety or upset, that's if it's too much right now, then it makes sense to back off. Um, if it's tolerable, even though intense, then my recommendation is usually continue for a few more days at that same dose and look to see what the trend is doing. If it's just maintaining or increasing, particularly if it's increasing, that's a sign back off. If it's getting better, that's a sign that it's likely to continue to get much better and be tolerable. Um, there was a side issue related to that backing off. Maybe it'll come back to me, but it was I thought interesting aside that I've completely slipped my mind. So I encourage patients in the first week of starting a new medication to call or email or text, what they're feeling, if they're worried or concerned. Again, I do try to warn people ahead of time. And usually, particularly with stimulants, my preference is to see someone back in a week, but different people practice differently. Now, so another question is what happens if they're only having side effects and not having any benefit? Again, then my usual approach is, again, looking at the trend, but to tell them encouragingly, we at least know this is having some effect on your body. Hopefully, we can get to a place where it's tolerable, and then potentially try increasing then to see if you observe more of a benefit, and trying to use as objective measures as possible to sort out whether they're having any benefit. Trying to so there was an aside, but it's slipped my mind. So, hello, Mr. Alec BG. What's my experience in diagnosing twice exceptional patients with ADHD? Are there any particular symptoms you have noticed? Um, so I don't even use the term twice exceptional. I would say every patient's an exception. They are an individual. Are there certain traits? I mean, and this is going to sound snotty or biased, but since most of my practice life was 30 years in San Francisco, just by objective measures, it's a highly educated, wealthy, and sort of highly intelligent population. Um, so I think compared to the colleagues when I talk with particularly local ones with ADHD, I saw two different pools of people. And one is highly successful, intelligent people with definitely clear cut, moderate to severe ADHD. And I also, partly because I took Medicare and Medicaid patients from the beginning, and for much of my practice, they were each a third of my practice. So I also saw a pool of people who were much less functional, many on permanent disability and or underperforming financially. So I don't know what else to say there. So thanks, Max, for including a video on the honeymoon period. And if I'm not getting at what you're referring to, so twice exceptional patients also to me smacks so much of the claims of ADHD being a superpower. And yes, we should acknowledge any advantages. We should acknowledge any potential benefits or differential effects in a positive direction. But part of why we talk about it, part of why we treat it, part of why we identify it is because on the whole, it is clearly and robustly associated with a range of more negative outcomes in terms of mortality, longevity, marital happiness, educational attainment, financial success. So Mr. Alec, Alec BG asks, how common it is for patients who have higher functional ADHD to be treated for anxiety or depression before ADHD is identified? I see it across the spectrum. I mean, including many of, and part of this is that I've been doing this for 30 plus years. But many of the people I originally started working with in the Medicare or in the Medicaid system had been in the system for decades, had severe ADHD, which was completely unrecognized, and were being treated or told that their problems were anxiety, depression, or in some cases, substance abuse, or in some cases, all of the above. Um, In this day and age, is it more likely that these are high-functioning individuals who the treatment team is only seeing anxiety or depression? Um, I would actually say my experience is that the higher functional individuals tend to be more aware of what's going on in society, so it's less likely that they themselves have no awareness of ADHD. Um, so I get that someone who I certainly have met many in so again, overall, I think ADHD is still being underdiagnosed. And yes, it can often be confused or symptoms attributed to anxiety or depression. I see this areas where I see it particularly are in couples therapy, where someone's ADHD driven behavior is attributed to narcissism or passive aggressiveness or X, Y, or Z. Most often, those are non physician mental health practitioners making those misdiagnoses. And I've certainly had high functioning doctors, lawyers, architects, others being told by their treatment team, oh, you can't possibly have ADHD if you achieve this level of educational and professional success. And that's clearly just rubbish. Um, so, so James Alexander asks if no positive effect is felt for a stimulant, how soon after starting on a given dose would you increase it? So, getting back to the earlier question, if we're assuming side effects are either negligible or completely absent, my recommendation is to only stay on a dose 2 or 3 days before going up. Um, and it's not just the stimulants, but I would recommend that for bupropion. I would recommend it for Strattera if you can tolerate it. Guanfacine, I wouldn't. So all of these drugs, with the exception of guanfacine, as far as we can tell, most of their benefit is a direct, immediate effect of boosting availability of dopamine and norepinephrine. Those are immediate effects. So if you're going to benefit for ADHD, you would expect them pretty quickly. Why I don't say just a single day is that everyone has day-to-day variability. Probably people with ADHD have more variability than the general population. You might have slept poorly. You might be freaked out by a test coming up. You might be elated that someone texted back that you're going to have a date later this week. Lots of different factors affect where our where we are in our mental space each day. So that's why I would say a single day sometimes it's not a good enough measure. Usually 2 is pretty good, and I would argue 3 is on the conservative side. There's absolutely no point in keeping someone 4, 5, 6, 7, 8 days on on dose of a stimulant if they're not seeing any benefit or side effect. Why? Why would you do that? You're just wasting their time, and so that's my answer. So Mr. Alec is getting back to the gifted, that he was diagnosed both with ADHD and also in a gifted education program when he was young. There were some issues, but didn't cause a problem. So, so I think I do have a video on intelligence in ADHD. And so one is if you just look at averages, someone with ADHD, the average person with ADHD's IQ is slightly below the general population level. And that is misleading because it's skewed by some people with severe learning, autism, a combination, multiple conditions at the same time. ADHD is overrepresented in that group. So that brings the average down slightly. But what we know is people with ADHD are present in every single quartile or percentile or all across the spectrum. There has been some discussion, and to my knowledge, not a lot of compelling data collection as to whether people with ADHD are overrepresented at the extreme intelligent end of the spectrum. And some of the claim is that people who think differently, that there's weak evidence that creativity is higher if we define creativity by coming up with novel solutions to problems or nonlinear thinking. So in that context, I mean, there's certainly a number of individuals in this category. Whether they are disproportionately high or not is not clear to me. Um, and it does cause, maybe even more confusion among teachers and classmates. It's, you're so good at this, how come you're not doing well in your other subjects? And again, part of the explanation is that, or I don't know if this really explains it, that ADHD brains tend to be interest driven and other brains tend to be importance driven. So a neurotypical brain who's smart gets a message they should perform well in all their classes, and they try to perform well in all their classes. The ADHD brain gets the same message, you should do well in all your classes, and likes math and science and isn't interested in history, so they do well in math and science and don't do as well in history. Um, so uneven performance or consistent inconsistency is one of the hallmarks of ADHD, and that can be particularly perplexing to people who are, if someone has strong intellectual strengths to begin with. So I see there's more of you out there, and there's no such thing as well, I'd say potentially there can be a stupid anything, but I haven't heard or seen any. So don't be shy about asking questions that are, again, either on the videos I released or on other ADHD topics or mental health more broadly. I should circle back to one of the other topics that's come up several times in the comment section and did come up in last week's session, and I said I'd look into it, is there is at least some research on lamotrigine for ADHD. So it is somewhere in the long queue of potential video subjects to come up with. Um, so lamotrigine is initially an anti-seizure medication. It's been FDA approved for treating bipolar depression, and apparently some evidence that it can actually help with ADHD. So Max asks, how useful do you think IQ is as a measure, and is it overused, overemphasized? Do you think other measures of intelligence should be used instead? Yeah, I mean, in day-to-day experience, about the only time I hear people even talking about it are, I'll do some president bashing, or people like Donald. I don't see many times when we're getting neuropsych testing that's a prominent or even part that's emphasized. I think so. So there's, I mean, a different emphasis in a school setting than in a mental health setting. I think there is still probably more value placed in it and attention paid to it in the educational realm. But even there, I'd say probably more so 40 years ago than there is today. Um, so yeah, I mean, I think it is a measure. It certainly has social elements. That certainly does have fairly good predictive value in terms of general range of performance in academics and very general performance in life, but certainly other factors such as emotional intelligence can mitigate that. I think we have better measure. I think as a measure of intelligence, it's certainly a better measure of intelligence than things that aren't even intended as measures of intelligence, such as the dementia screening tests that, again, a certain president keeps bragging that he has passed. Those are not measures of intelligence. They're not intended to be measures of intelligence. So that's where I'll leave that. So, Alec BGS, are there any pipelines for non-stimulant ADHD meds you're aware of, lamotrigine notwithstanding? So I mentioned last week, because I had just come back from the APSARD, which is meeting. So APSARD is the Association for Professionals and Research on ADHD and Associated Conditions. And I had not been to the meetings in several years. My recollection of when I went a few times several years ago, maybe even pre-COVID, that was, to me, since I'm not plugged into, I'm not an academic faculty anywhere, I'm not hobnobbing with researchers in the field routinely. That was my best opportunity for finding out what was in the pipeline. I mean, periodically there's reviews or papers written of things coming down the pipeline. Most often, by the time those get published, many of the items are either discarded by the drug companies investigating them already, or it's already been leaked that they're useful. Um, anyway, the APSARD meetings that I remember had multiple hours-long poster sessions, and it was a wonderful opportunity for drug companies to present preliminary data on what they were working on and things that weren't out there in the pipeline. So I was quite disappointed at the very recent APSARD meeting. One, they only had one poster session and less than 100 posters, but only an hour to view them in. Two is that there's nothing in the pipe, and I won't say nothing. So there were 7 or 8 presentations on centanafidine. I did a review of that on this channel, I think now more than 2 years ago. So it's been in the pipeline that long. It is much closer to FDA approval. It's a triple reuptake inhibitor, dopamine, norepinephrine, and serotonin. Seems comparable to other ADHD non-stimulants out there. There's also several posters on Qelbree, particularly on my recollections, using it with stimulants safely and that it can address emotional um, dysregulation in ADHD. And that was it. I mean, there were other posters on coaching, on social aspects of ADHD, but in terms of substances in the pipeline, I might have missed it, but I was looking and I didn't find anything out there. There might have been one or two on solriamfetol, Sunosi, which I've also reported on, I think now more than 2 years ago. It's approved for narcolepsy, and they're working on getting an indication for ADHD. But again, if it's something talked about more than 2 years ago, I mean, the alarming thing is the pipeline that barren, or are companies holding back their research, or are we just at some kind of plateau or stasis? I don't know. So I'd say the other thing that I've seen more and more research on, and that's part of why I am talking more and more about it, is um, non-pharmacologic, but supplements, so things like taurine and tyrosine and spices like saffron and turmeric and um, plant kingdom and mushroom kingdom, things like lion's mane. So most of those are being promoted or investigated by smaller budget, not big pharma. So that may be why there's less likelihood to be rigorous research presented at meetings like this. Core Focus 26 asks, is there a correlation between ADHD and obsessing on details? Diagnosed in late 40s, reflecting back on engineering class, I really focus on trees before I could see the forest. So two things. I mean, one of the things I often use to describe ADHD is that the whole world is, what's right in front of you, and it's harder to contextualize or remember what's around you. So that's not necessarily the same as obsessing on detail. It's saying where your focus is likely to be, and it's harder to step back or process. So that is absolutely a common aspect of ADHD. There's a separate, related, and overlapping issue of obsessing per se. And obsessing means returning or spending lots of repetitive time focused on it and going back to it over and over again because it's hard to let go of. So, hard to let go of, and switch framework is also an ADHD aspect. In some level, it seems that obsessions is the opposite of ADHD. If we overly caricaturize, the person with ADHD is bouncing from topic to topic. But again, ADHD isn't the inability to focus or pay attention, it is less control over attention. So that can be more trouble locking into what you want to lock onto, but it can also be having more trouble extricating yourself or switching on or moving on when it's appropriate to do so. So there is good evidence that something like 25 to 30% of people with ADHD have some obsessive level symptomatology that's would qualify them for something in the OCD category of diagnoses. So OCD symptoms are overrepresented in the ADHD population. And again, I do think I have a video on that. So thanks, Max, for providing the links to tenafidine and to Sunosi, which is solriamfetol. And Sunosi is a dopamine and norepinephrine reuptake inhibitor. So our core focus is going on. I would go into such detail, I would get lost or confused. I'm just wondering, yes. So I hopefully answered that before I saw the second part, but that's absolutely a classic ADHD symptom. And again, it's tied to being able to regulate or voluntarily direct your ADHD, your focus, rather than having internal processes locking on when it shouldn't necessarily lock on. Restless Lamb asks, under what circumstances in an adult would you add guanfacine to a stimulant? Trying to figure out if it would help me and whether to bring my doctor. It's a good question. So one situation, a common one, is people who have some benefit from stimulants, but even at fairly low doses are feeling more agitated, more revved up, and dropping to a lower dose eliminates both positive benefits and the undesirable side effects. So in that situation, there's many people who either just keeping the stimulant to that level and adding guanfacine, or sometimes if it's intolerable, stopping the stimulant, starting guanfacine, and then if that guanfacine itself isn't enough in guanfacine, you really do need to wait 2 to 4 weeks to see what you're getting, then adding back in a stimulant. Other situations, I'd say usually the biggest sort of compelling one is if there's a fair amount of anxiety, sometimes sleep issues per se, sometimes just fear of going higher on a stimulant for their reasons. Again, I'm not usually fearful of going higher if, again, side effects are not a problem. Again, what other aspects other than anxiety? Um, and one dimension that I haven't been impressed with clinically is some people who get benefit from the stimulant during the daytime, and then as it wears off and crashes, they're feeling less functional late in the evening. And theoretically, guanfacine and maybe Strattera and some others have more 24-hour coverage. That could be one. Another one is people who have mild elevations in blood pressure and are concerned because guanfacine is a blood pressure lowering medication. So particularly if they're already on a different antihypertensive, it often makes sense in consultation with the cardiologist. Or could we sort of kill two birds with one stone and omit the other, replace their existing antihypertensive with guanfacine, which hopefully will treat their hypertension and help with their ADHD. What are other groups? I haven't seen that there's one particular set of symptoms or that it helps differentially, again, other than maybe the anxiety realm compared to this. For a second, I hope I am back. So, Max, thanks for providing the OCD ADHD link. So, Alec BG finds himself needing to research or do something new at basically all times. Otherwise, he feels down or unstimulated. So, and that's classic ADHD. And hopefully, it's a part of the trick is finding a job or finding friends or finding partners where there's at least some feeling of novelty and discovery in what you're doing each day. So, James Alexander, how could a patient actually pursue a titration plan of upping the dose after just a 2-day or even 3-day trial of each dose, given how psychiatrists approach stimulant titration? Most seem to strongly oppose to stimulant dose increases more frequently than once or twice a month, which most likely, much like how most psychiatrists are strongly opposed to going above the max FDA recommended dose for stimulants. What would the prescription for a quick titration like that for, say, Vyvanse look like? A combination prescription of 10 milligram pills, 220, 230. So, so one is I often don't spell out in the prescription exactly how we're titrating upwards. Some pharmacists don't like that, but some also object or get confused if you clearly designate it. I mean, so for me, the strategy, and I wouldn't, well, if, if someone's completely new to stimulants, often because Vyvanse goes in more slowly and gradually, and some people don't feel or notice it right away. Some more often, although I'm not seeing a lot of new patients, and part of this is predicated that Vyvanse is an expensive option. So one is just to write a multiple number of a low dose, say 5 milligrams of Adderall, and write for 60, and tell the patient, start with 1 today, 1 tomorrow. If it's too much, if you're feeling revved up, contact me. We can discuss how bad it is. If it's too bad, stop. That won't work. If it's, again, tolerable, we may continue longer. Um, but then again, go up to 2 of those a day. And then after 2 or 3 days, go up to 3 a day, depending again on what you're seeing. So one, and then I usually include written instructions for the patients so they can have them and reference them, because even if they're nodding and shaking their head and seeming to understand, very often they're not. 2 is, again, seeing someone at least in 2 weeks, but usually a week after a stimulant. I mean, part of it is I am more willing to let someone experiment, knowing, one, there's a tendency for ADHD patients to experiment anyway, that's inherent part of the condition. And 2, again, you're wasting their time, you're wasting your own time. You just have more information to work with on the follow-up if they've tried 5, 10, 15, and 20, rather than they've just sat at 5 and it's not working. So, yeah, I mean, I wouldn't prescribe 100 pills of 50 milligram or 30 milligrams on the very first session, but I would write enough to fluctuate, and it might mean that a week or two later I am writing a new prescription. But if the dosage, usually that's going to be allowed by the pharmacy uh, and the insurance because you're at a higher effective dose now. So I don't know if that made sense. So usually, again, it's much cheaper to write a large number of a low dose than to write for multiple. I mean, one, it's a bigger hassle for the pharmacy to deal with. Two, even with good insurance, a person might be facing multiple copays if you're writing for 20 milligrams of Vyvanse and 10 and 30 and 40 and 50. Um, so that's some of my approach. Okay. So I hope if that isn't enough, I can answer more, James Alexander, if that. So restless lamb, I've noticed that the newer meds like Daytrana, Mideas, Jornay, and Asteris don't get discussed or prescribed often. When would one get prescribed these? What are their strengths in your experience? So I don't have any ties to the industry. Many of the prominent researchers have been paid to help develop and clinically test these products. So not that they aren't smart and knowledgeable. I'd say most of these, I mean, and there's 10 or 12 different versions right now that slightly tweak the ratio of dextro to levo forms or slightly tweak the ratios of immediate release on the coating. So I think for me, one is that Vyvanse, the slow release mechanism, which is cleavage of the lysine molecule, really, and it was discovered, and I have a video, it was sort of not developed for this reason. It was developed to be not attractive to people abusing their medications, but it provides a wonderfully smooth onset and a very well-regulated delivery over the course of the day. Daytrana being a patch has a advantage in that people who don't like or can't swallow, that's a different mode of delivery. Mideas does last longer than just about any of the extended release forms, so I use it occasionally for that. Jornay, I think, has a special niche. It's the only one that you take the night before, and the coatings on it prevent any release or less than 1% of release in the next 10 hours. So you can time it so you take it at night and it's starting to work right when you need it in the morning. That, I think, is a big advantage. Asteris, I haven't researched as much or used as much, but it uses the same principle of a prodrug that needs to be cleaved for methylphenidate in this case, not dexamphetamine. All the others, I think, are Me Too, meaningless distinctions. I certainly have had some patients who came to me and felt that Ritalin LA was the best option and that they had tried multiple others, or Adhancia was the best option for them, or X, Y, or Z, Ezekiel worked better. And there could be aspects of pharmacodynamics that make a certain drug a good fit for a specific individual. But I haven't seen overall, none of these others jump out. Again, the ones you focused are the very few among the options which I think are sort of distinguishable or have some unique role. Um, so and given that all these branded ones cost way more if you have to pay out of pocket, sometimes insurance covers them. They just don't seem to have much added benefit in my experience. Richard Nixon, and I have to be careful for the time now because I do have to end in 5 minutes. What how to counteract armodafinil-related sleep problems. So armodafinil does tend to last long. I mean, one is making sure you're taking it at the same time each morning. So, there are circadian rhythm effects going on here that are important for optimal functioning. And even if taking it right when you wake up or taking it before you wake up, going back to sleep for an hour and then working most of the day doesn't work for you. Modafinil, which is a combination of R and L modafinil, for most people has a considerably shorter half-life effectively, so that may be a potential option. James Alexander is referring to a previous video. That I don't that I haven't worked with a large number. I mean, I'd say the biggest explanation is I stick to the criteria for diagnosing autism, and that doesn't maybe properly address people at the milder end of the spectrum. That's my conjecture there. So you're welcome, Alec BG. Rick 007. And I don't know if you were here at the beginning, but I was trying to answer your question about hippocampal damage from a mounting. So get back to me if you weren't here at the beginning and I didn't answer it enough. I only have 3 minutes left. Thoughts on kratom? Seems to be demonized quite a bit. I I've not even I mean, it has been demonized so much that I haven't even looked into it. So I don't know I of any potential benefits for ADHD. I will check and get back to you. So restless lamb, would Jornay be good for insomnia or Daytrana? Again, Jornay potentially could help, again, given that if you are regular with the timing, you may be less exposed. Psychiatrist is more interested in following the regulations and laws rather than helping them. I'd say I hear that. So one is a trend that was already present when I was in training more than 30 years ago, is that insurance companies want doctors to be pushing medications and don't want them doing therapy because they can pay someone with less training, less amount of money to do therapy. I've always done both. I don't see them as being separable even. But there's an increasing trend. Fewer and fewer psychiatrists got much training doing therapy and are more accustomed to the 15-minute med check or the 20-minute. I never see patients less than 25 minutes, and almost always those are 30 minutes because I don't do a good job at kicking people out the door. So yes, unfortunately, what you're experiencing, I hear a lot of. I don't know what's the best way to. I mean, I would say ideally people did get into medicine because they wanted to help people, and it may take work and it's unfair, but trying to find that or unleash that or activate that in your provider is maybe a pathway in. Yep, so that's Cupcake there. What should I do? What if my iron level's at the very bottom of normal, but my doctors won't offer me IV iron? As restless leg syndrome, brain fog, and fatigue. I don't absorb oral iron due to past cancer. I mean, yeah, I don't have a good answer there. I mean, I would maybe the oncologist or whoever treated you is more open to treating it or open to explaining to your other doctors why it might be important. I'd say maybe bringing in articles or summary. I have a video on restless leg syndrome, but a strong association with low iron, and much better to be treating it by fixing iron than by adding on other medications. So that would maybe be my strongest argument. So thanks for being here. I'll be back next week, and I've run out of my time.